Brilliant. So it's 1 o'clock. I can see a few more people joining us, and I think we'll probably get cracking and people can join as we go, just because there's an awful lot to get covered today. So a huge thanks to everyone for joining. We know primary care is incredibly busy, so we really do value you taking the time to be with us here today. So a big welcome. My name is Kat Hodges. I'm the Surrey Primary Care Lead for the Surrey and Sussex Cancer Alliance, and I'm a salaried GP in North West Surrey. And I'm joined by my colleagues from the Alliance. We've got Jo Thompson, who is a GP partner and the Sussex Primary Care Lead. And we've also got Steph Bell, who's our Cancer Outcomes Improvement Manager, and Martley Isaacs, who's our Data Analyst. Just to say a couple of housekeeping bits, please do feel free to enter questions for us. We will try and answer what we can as we go through, but if we don't manage to, then we will look to answer that after the session. And just to note as well, the session is being recorded, so you will be very welcome to review everything after the webinar, and also pass on to any colleagues. So yes, hopefully it's going to be a really useful resource for you going forward. So this is our agenda for today. We've only got a short hour to cover a really huge topic, but we have put together a toolkit which is just in the final stages of being reviewed, and then it will be hosted on our website. And this webinar is really to give you an overview of this and get you to start thinking about working towards the earlier diagnosis of cancer DES requirements. And just to say, we do recognise that primary care is constantly being asked to do kind of more with limited time and resources, and that we're in a very challenging environment. And the idea behind this today is to really give you some simple ideas to take forward in practice that aren't overly onerous, but do lead to better outcomes for our patients in the future. So we're going to have a bit of an introduction, an overview of those requirements, an introduction to some of the data, and then some really kind of practical next steps that you can take within your PCNs. So the NHS long-term plan really sets out an ambition that by 2028, the proportion of cancer diagnosed at stages 1 and 2 will rise from about half now to 3/4 of cancer patients. And NHS England estimates that achieving this will mean that from 2028, 55,000 more people each year will survive their cancer for at least 5 years after their diagnosis. And early diagnosis is really key to that survival effort. So if you diagnose cancer at an early stage, there's a much greater chance of being able to treat the disease successfully, often with less invasive procedures and fewer long-term side effects. And people diagnosed earlier with cancer are not only more likely to survive, but more importantly, have better experience of care, lower treatment morbidity, and improved quality of life compared with those diagnosed late. So really kind of key to be keeping that in the back of our minds about that importance of that earlier diagnosis, and why it's so key for primary care to be involved. So this slide really is just to kind of set the scene a little bit. It's showing the stage of diagnosis in 2018 for lung cancer on the left and pancreatic cancer on the right. And we just wanted to illustrate that there's a huge variation by CCG and cancer type for early stage diagnosis. We will share other tumour groups in the resource pack, and these really kind of hopefully will enable you to see where you might want to focus work, since there are areas that you may fall below that England average. And actually, even for those where you're above that England average, when you look at it at PCN level, you might find some discrepancy. And it's interesting to note that sometimes even areas, they don't necessarily tally with the most deprived areas or the affluent areas. And so kind of delving into that data and looking at the reasons behind the patterns at PCN level is really helpful. We asked you to kindly complete a bit of a survey before this webinar, just to get a flavour of where people were at with this work around the PCN DES this year. And this is just a summary of some of those questions. So the focus of people who've started work. And you can see that most people are looking at that screening aspect and also at fit and then improving referral practice. There's a fair few number as well who haven't yet started work, which is completely understandable, and hopefully this will be helpful for all of you in doing the work going forward. We also asked people just to rank where they felt that most impact could be made in primary care on early diagnosis improvement. And again, this was kind of felt to be around the screening and improving referral practice. And we're going to share some really practical tips and ideas around these areas, as well as some of the other areas as well that you might be able to do it within your PCNs. So just to flag that the DES really highlights that role of primary care in the wider system. And I think PCNs have a really unique position to look at the variation in their data, to build consensus, look at implementing best practice and holding each other to account. And there's also that possibility to benefit from operational economies of scale. So in our resource pack, you'll find a wealth of resources, but there's some really, really brilliant resources there to find within our resource pack, and we will signpost you onto those. So I'm just going to hand over to Joe now. He's going to talk you through some of those early requirements.
Hi, thank you, Kat. So these are the domains that are within the service requirements for the DES for 2022-23. And what we're going to do is we're going to break them down into each of these sections and just kind of give you, as Kat said, a high level overview of what the kind of things you can be looking at. I think what I want to really say is that although there's a lot of information in these slides, actually, you know, some of this is really achievable. So it's about making sure that you're thinking thinking small, really, rather than thinking big, which will make it a lot easier to manage. Thanks, Steph. So the first one I'm going to come on to is looking at referral practices. So the PCNs must review the referral practices for suspected and recurrent cancers as well, and using the wider community of practice to actually implement some specific changes to enable this to happen. And I think the golden thread for all of these requirements is looking at inequalities. So looking particularly around the disadvantaged populations, such as people with learning disabilities or serious mental illness, or some of the ethnic groups, for example. So one of the things that we can do around this is at PCN levels is to actually look at how you make the referrals. So looking at the quality of referrals is the easiest probably, and one of the easiest way of doing that is just to make sure that you're up to date, you've got the most up-to-date pro formas actually within the system. You know, we all know that we've all had 20-year-old desktop items knocking around, and they're easy to use, but the latest referral pro formas should be used, which tie in with NG12. To help this happen is the use of clinical decision support tools. So one of the things that the Alliance has recently funded is the use of Ardens across the whole Alliance. And this will ensure that all of the referral pro formas are kept updated, so we won't have to necessarily be doing that manually in future. Some of the things you can do at PCN and practice level is to actually look at the patterns of presentation of cancer diagnosis. So to see whether perhaps you're in line with the national targets, for example, of referrals, making sure that you're making enough 2-week rule referrals. Are there particular areas that you're not meeting, such as urology referrals, for example? We all know they all went down in COVID. And the other thing which is really useful to do is looking at emergency presentation audits. So to actually audit the number of patients within the PCN that actually are diagnosed through an emergency route. And that can be done to inform kind of a retrospective look at those patients to see whether there are any opportunities for earlier diagnosis. Alongside the referral quality is around safety netting, and to make sure that patients have got the right information to hand, so consistent safety netting. One of those things is to use the SNOMED codes, which will be in the resource pack, to ensure that the patient has been told that they should receive an appointment within 2 weeks, and if they haven't got that, to contact the practice, but also within the practice to set up systems to improve analysis that those patients have actually been seen. And the other part of that is to signpost patients to information around their referral, so that they understand that it's an urgent referral, they understand it's a cancer pathway, and that they understand that they need to attend. What we're doing at the Alliance to support this work is to update all the referral pro formas, and alongside that we're creating some ICE profile boxes on the path link, so that when you go in and, for example, make a 2-week rule referral, you'll be able to just tick the 2-week rule referral box for cancer referral for that domain. As we've said, we've put Ardens throughout the whole practice, throughout the whole Alliance, so that will certainly help to make sure that all the forms and any of the links within the forms are all kept up to date, and will hopefully make your lives easier in negotiating some of these things. We've also, as Kat said, done the dashboard, which Martley's going to show us a little bit later, which will allow you to kind of delve more into your PCN level data to really identify where you want to focus efforts. And all of these links will be in our website, so that there's one area that you can access all of this. The cancer referral patient leaflet has also been published, and again will be hosted on the website, and it's also going to be done in an easy read format in 13 different languages. And the toolkit, again, will be available to everybody after this presentation. The idea of setting up this group is to enable us to kind of move forward and do some targeted education around things like the Ardens profiles and certain kind of areas of the DES if that's needed. So it will hopefully kind of give a community of practice for the cancer leads across the patch. So this is a kind of, you know, a kind of more in-depth idea of what you could start doing around improving referrals. So one of the things, if you haven't done already, which I'm sure most people do, is to formalise a kind of meeting to actually look into previous cancer referrals, thinking about whether there's any opportunity for earlier diagnosis, and looking to see whether there's any themes that come out of those meetings to say, you know, to focus work. Another really simple thing is to make sure that you're actually consistently across the PCNs doing the same thing. For example, using AccuRx to send a leaflet to patients who are able to use the text messaging services, making sure that all of the languages that you have are relevant to your kind of patient population groups. Okay, thank you. This is what you will see in the pack. Don't worry about reading it in too much detail now. This is a kind of plan on a page, and we'll have one of these for every single one of the requirements. It just kind of gives you a sense of where to start, really. And another example is kind of how to go about thinking about safety netting. So this is one of the CR UK slides. Again, it's very simple. You can work through these quite simply. Thanks, Steph. So going back to the Ardens, so this is available across the entire patch. And this is more kind of for practice processes. Think about actually how you make your referrals. You know, some people do it contemporaneously, some people will do it at the end of surgery. Some practices I know kind of send them to secretaries to do. So everybody does it very differently. But if you can kind of agree a way of kind of making referrals within your PCN, that would be a good place to start, and making sure that you're actually auditing those 2-week rule referrals to ensure that everybody is being tracked before they reach the hospital, and to make sure they have reached the hospital and that you're picking up anybody that hasn't actually been seen. So those are some of the areas again you could look at, and Ardens will facilitate that. Sorry, Stan. The other thing you could do is to make sure that you've got a kind of library of resources available for patients. This is just one example for breast pain, for example. If you scan the QR codes on this webinar, you'll be able to kind of take away to the links that give you the breast pain leaflet. There's other things available like cervical screening leaflets from Joe's Trust, for example. So again, you know, just having these things available at PCN level and an agreement of, you know, which you're going to use and which you're going to signpost to. This, I think, is probably the most helpful slide. Again, it just gives you a way of kind of plotting and showing that you've actually, you know, what you've done and whether you've, you know, what you've particularly looked at. I think if this is just really for you, it's not for anybody to mark the homework, as it were. But if you would be willing to share them with us, I think that would be really helpful for the Alliance going forward, just to see, you know, where everybody has focused their efforts. So feel free to, you know, share them with us, and hopefully with this group we'll be able to kind of share together what's been the challenges and what you know, what we've learned from it. So the next requirement is for screening, which is the one that I think most people are focusing some kind of efforts. It's to improve kind of uptake in cervical and bowel screening, particularly, and follow up on the non-responders and to identify the reasons really why they're not responding. So this again builds on the work that probably we've all been doing and we were doing through COFQI as well, but also builds upon the kind of the inequalities thread. So again, trying to include, well, must include at least one specific action to engage with a group with low participation locally. These are our kind of numbers of the screening trends across Surrey and Sussex. I don't know how easily you can see that slide, but basically the bowel cancer screening has improved slightly across the years. I think that's probably something to do with the fact that the FIT testing is actually more acceptable to patients now. Cervical cancer screening, we're still above the England average on, you know, across the whole of the Alliance, but certainly within pockets of that, you know, we're not meeting the targets that we're wanting to achieve, which is 80%. So again, there's a lot to be looked at within these. So this is a bit more information around the bowel screening. We're all meeting the national target of 60%, but even within PCNs, there will be some practices that are way above that level and some practices that are below that level. And it's really looking to see why that is. Thanks, Steph. And this is the kind of an overview of the cervical screenage coverage as well. Again, as you can see from this, you know, the screening target is 80%. We're consistently below that across the whole of the patch, and some areas are more challenged than others. So again, it's using this kind of information that will kind of allow you to look into to do a bit of a deeper dive into that. And again, as I say, there may be some practices within the PCN areas that are actually achieving higher than 80% and others that are achieving, you know, well below that. So sharing the learning about what's worked and what hasn't, and supporting each other in you know, improving those numbers will be great. So one of the things you could do is to, well, I think look at your own PCN level screening data, understand it, try and work out, you know, whether there are particular groups that aren't coming forward. It's often the younger patients we find, but, you know, there may be patients from different ethnic minorities that have cultural reasons for not coming forward. Tackle the inequalities. So you actually look at those and focus some of the work on tackling the inequalities there. Try and contact the non-responders. Again, one of the valuable things that has been done is to actually make contact, human contact with those non-responders, perhaps identifying somebody in the practice that could ring some of those people, signpost them to documents, try and find out why they're not coming. You know, it could be for a multitude of reasons, possibly because the screening's on a, you know, it's difficult for them to attend work, and make changes around what you learn from that. And then also looking at the local initiatives that are going on with the public health commissioners, for example, and the local integrated care systems. So everybody's got a cancer lead in their patch within the ICS. And hopefully, you know, the ICSs are giving some information about what's going on in the local area, but also thinking wider about that, thinking about the national campaigns, supporting the national campaigns at PCN level and practice level, thinking about having a cancer lead who kind of drives the process, maybe some cancer care coordinators within your R's roles, for example, so that they can actually do this focused piece of work for you. What we've done, again, we've touched on some of this, is to create the dashboard, which will allow you to provide some of the more up-to-date data. Martley's going to come on to that. This group is essentially a network of like-minded people. Hopefully, we can use this group to support each other. There is also a community connections database that has been developed by the Alliance, which has a lot of groups, faith groups, religious groups, ethnic groups, and all kind of included on a database. So if you ever wanted to get hold of anybody that would represent a particular population, that's a good use. That's a useful resource to know about. And obviously, get in touch with any of us if you're not sure and want some guidance. Thanks, Steph. Thanks. So again, I think we've touched on this pretty much. You know, how looking at your PCN level data, have a look at how many people have responded for their cervical screening invite. You know, and then contact the non-responders, actually have a conversation with them, find out what it is. Think about looking at a specific group of disadvantaged patients, potentially, or patients that we know that don't come forward as readily, some of which often is the serious mental illness or the learning disability cohort patients. Think about how you can support that particular cohort, thinking about, are you mentioning at annual reviews? Are you giving them easy read leaflets? Are you understanding the barriers for why they're not coming forward? Thanks, Steph. And this is what I was saying about making it easy. So really focus in on a very kind of smart objective, essentially. So think about kind of, you know, what you want to achieve. Trying to don't try and change the world all at once, essentially. You know, think about the numbers, think about the percentage you want to improve upon, looking at, for example, cervical screening, you know, looking at the barriers, contacting a percentage of those, how you're going to contact them, and then what you're going to do to potentially change practice going forward, having understood a bit more about the issues there. Thanks, Steph. This is essentially that in a slightly different format. The kind of improving screening uptake and improving inequalities. Possibly the more elderly patients, are they computer literate? Do they access information in the same way? Look at the ways that you can make sure that everybody is getting the same information. Think about, for example, for your transgender and non-binary populations who still have a cervix, how you'd access them, how you'd make sure that they're given the right information, how you actually make sure that you're actually contacting them and making the screening a kind of safe place for them to be able to come comfortably to have their screening. Think about working with the mental health teams to highlight cancer screening as part of the SMI reviews, and use the wider kind of networks of things like the patient participation group to improve kind of awareness and try and improve the awareness of the national campaigns as well, and sharing updates on the websites. Again, that's all demonstrating improvements. The Community Connections bulletin is something that the Surrey and Sussex Cancer Alliance puts out, which you can find on the website. Again, you can tap into some of these resources. And Bobba is our community engagement lead, and she is fabulous and will always come back to you if you wanted to particularly reach out to certain groups. Thanks, Steph. Also, there's masses of resources out there, so you don't have to reinvent the wheel. So think about using some of these to help with the screening improvement. One of the things that we've done in our practice is just signpost to a video for Joe's Trust, and also to see about kind of easy read leaflets and very much more of a kind of bowel screening information that's easily available, and how-to guides. Again, this is another template. Again, I would say if you print these off and just keep those to the forefront, that will help you work through some of the different domains. Thanks, Steph. Right, I'm going to hand back to Kat now and her little helper to go through the other requirements. Thanks, Kat.
Thank you, Jo. I'll just mention one other thing with the cervical screening, which will be hosted on the website, our website as well, is just that the immunisation team have developed a standard operating procedure for cervical screening. And I think I would just signpost you and your nurses to that, because I think it will really, really help with ensuring that people are called at the right time for their screening, and also looking at some of the issues that the lab have with labelling and other things, and within that there's kind of a checklist that again will be quite an easy process to go through, but improve the numbers of screens that are actually being able to be processed. So it might be a useful one for you to think about looking at as well. So as Jo said, I'm going to move on to the third requirement. So this is looking at fit. So PCN should work with its core network practices to adopt and embed the requesting of fit tests where appropriate for patients being referred for suspected colorectal cancer. And to fulfil this requirement, it's recommended that fit testing is done for all appropriate patients on a lower GI urgent cancer pathway. And that's either providing the fit test to patients to accompany that urgent referral with the expectation that the fit triage will take place in secondary care, or using that fit result for practices to decide whether that referral is appropriate. And I think, people have a different knowledge level about fit, and it's definitely something that we will be looking at an alliance level to do some education around this. But certainly there is an expectation that at least 80% of lower GI urgent cancer referrals should be accompanied by that fit result. Just to note that this also supports the IIF indicator. So you have recorded either in the 7 days leading up to the referral or in the 14 days after the referral that fit result, and there is obviously a payment associated with that. So again, a dual one to look at in terms of the PCN DES and that payment indicator there. So in terms of practical actions at a PCN that you can take. So thinking about that local data collection system to track how many of those lower GI referrals are happening with or without a fit, and what happens to those referrals based on that result. And then really engaging with all primary care staff to raise awareness of fit. And that's, the use of fit as symptomatic versus asymptomatic, but also encouraging staff to give supporting resources to patients to communicate the importance of that test, and then implementing systems to safety net, so making sure there's really clear local pathways and information, and also just thinking, obviously, if there is a fit less than 10, that doesn't necessarily always rule out colorectal cancer or certainly another cancer, and what processes you have in place to be reviewing those patients. So in terms of some of the resources that we've developed at the Alliance, we have a Fit Admin Pathway poster. So this is available to download and print off and put up in your reception areas and show your admin staff. And really, it's just trying to support anybody who's giving out these kits, so the reception teams, and making sure that they're giving out the right tube tests to get the test done, because there are a lot of spoiled kits that come through with the wrong kit still. It's also just highlighting the importance of labeling it, and also highlighting to the patient how to do the test and when to bring it back, ideally within those 2 days. So hopefully this will make sure that people understand the process for patients, and we're reducing that spoilage rate, getting fewer rejected samples, and people are actually progressing for their suspected cancer pathway much more quickly by getting that fit result right the first time. Just a practical point there, just make sure that you've got enough kits. So again, a really simple thing that you can do within your PCN. The guide was that a normal practice require 1 to 2 kits per week, and a larger one about 2 to 4. But certainly, I think we're using fit more and more within our practice, and especially kind of within potentially younger populations. Deborah James side of things, flagging to younger people coming forward. So you may find that you go through those more quickly, but just making sure you've got adequate supplies. There's a really useful AccuRx sample reminder pathway for FIT. So this is again to kind of aid patient compliance in returning their kit. So it's an automatic text reminder that's now nationally available through AccuRx. So patients receive a text reminding them to return their FIT if they haven't already after a certain period of time, and you can adjust how quickly you want those text reminders to go out. So again, a kind of simple way of safety netting people within primary care to return that FIT kit. And there are kind of step-by-step guides of how to do that, and a video done by AccuRx, which again, all the links are within our resource pack. Another important thing is knowing the code. So accurately coding the use of FIT enables us to review our practice. I'm sorry, I'm going to hand over to Jo again. Apologies for my interruption here.
All of these are going to be on our website, so don't worry about taking them all down now. They're all in the pack. So that really does help. And there is a bit in the chat from, I think it was Deborah, saying that there have been some national issues with the timings of codings and things. It is something that the team are looking at nationally, and we will update you when we hear about any potential fixes for that. That's something that CR UK are looking into. Thanks, Steph.
Thanks, Jo, for stepping in. Apologies for the disruption. So again, this is just a checklist that we have around FIT, just to help us in aid memoir about some simple things that you can do. So as Jo said, worth printing these off and having them to as a resource between when you're speaking to each other at PCN level, and also passing on to us, so we're aware of what's going on and where we can support with changes. So hopefully that will be useful for you going forward. So the 3B requirement is around adopting and embedding teledermatology. So it's for PCNs to work where available and appropriate to use teledermatology to support skin cancer referrals, and noting that it's not mandatory for all referrals. And I think it's important to note that people are going to be at various stages of this across the patch. There are different projects running at ICS level. The teledermatology work is aligning with the fast diagnostic standard to ensure that patients are getting that definitive diagnosis of cancer, or communicated that it has been ruled out within 28 days of referral. And so, look at what community services are available for you, but it's definitely something that's going to be further developed at a kind of wider level to look at that pathway to speed up that diagnosis, manage those high volumes of referrals, and reduce some of the face-to-face flow through the dermatology clinics that are very challenged with that high number. So I think it's definitely something that, perhaps it may not be an immediate concern to address within the DES, but there are some practical things that at PCN level you can look to do to try and ensure that you're kind of fulfilling this requirement as well. So just encouraging, referring to the NICE guidance, the 7-point checklist about when to refer. And then if you do have some teledermatology services, using dermatoscopic images rather than patients doing it themselves, secure image smartphone apps. So there's Consultant Connect and Pando, and those can really aid that image capture in primary care. Thinking about the safety netting side of things. There's a useful bit on the CR UK Safety Netting Hub about resources for that. And then signposting to the Dermatology Digital Playbook. So that's a resource to provide clinical teams and organisations with digital tools to support the delivery of patient pathways. The other aspect is thinking about advice and guidance. So there's some really kind of quick turnaround times where sometimes people are unsure, and there are teledermatology pathways being developed nationally with integration with ERS as well. So take advantage of those where you have them. But as I say, I think it's a challenging one at PCN level to do if you don't have those pathways available yet. Practices have been funded to have dermatoscopes, so they should be available. And we're looking across the Alliance at our teledermatology services. And so we will share that report when it is available. And there's also an exciting project underway with eDerma to look at the AI side of skin evaluation. So again, that will be shared, but obviously do contact your local teams about what's going on in the area to see, what future developments there may be that you can be involved in at a PCN level. And certainly there is a lot of training going on as well with dermatoscopes. So seeing what there is there. There are some really useful things at base level you can do as well, just making sure the AccuRx photo is enabled, and training and upskilling staff in the identification of concerning lesions. And then one really, again, simple thing is just helping patients to make sure they send through a really good quality image. And there's some useful resources there that you can attach to AccuRx's when you're asking people to send those through to improve the quality of those. So again, we've got a checklist to aid with looking at those areas. So hopefully you will find that useful going forward. And then requirement 4 is focusing on prostate cancer, so increasing proactive and opportunistic assessment of it. Prostate cancer is the most common cancer in men over 50. We have more than 325,000 men living with and after prostate cancer in England, and more than 40,000 men are diagnosed with it every year in England, and 9,000 men die every year as well, so 1 man an hour. And we know that COVID had a dramatic kind of impact on our ability to actually refer people because they weren't presenting, and so there was concern that there would be a stage shift in the survival for prostate cancer. So this DES is certainly trying to address that and case find some of those patients. So in terms of practical aspects that you can do at PCN level, certainly looking at your urology referrals to see whether there has actually been a shortfall, and then identifying those men most at risk. So considering family history, age, ethnicity, and then proactively targeting those with information to then discuss whether, PSA testing and rectal examination would be indicated. Obviously, at PCN level, you could think about awareness campaigns if you're in a particular spot where there is a real shortfall and you've got a number of people who are at risk population. Again, just simple things, thinking about the face-to-face side for examining people with prostate issues, thinking about advice and guidance, and again, the safety netting theme runs strong throughout all of these. At the Alliance, we have developed a prostate case finding pathway, and this is to proactively offer people within agreed criteria the opportunity to have an assessment and a PSA test. So there's a pilot that's being started in Guildford and Waverley, but then it will be looked to roll out across the Alliance over the next 2 years. So hopefully this is going to really help, going forward with this DES requirement, although it may not be immediately coming to your area. We're also looking to get a mobile prostate clinic and link that into the project. And there's some really targeted campaigns that we're running alongside the national campaigns as well. So it's worth just kind of keeping in touch with our communications bulletins about those, so that you can put them in your practices and flag to patients the material there as well. I'll just briefly discuss the project that's going on. So it's partnered with a company called Medifer. So we think we're 3,000 short of these cancer referrals and 450 people short of cancer diagnosis in prostate. And the whole idea behind this project is to very much identify these men without adding workload into primary care. So we've kind of kept that at the forefront of the project, and really there are some occasional actions for primary care within it, but it's very much a project that's being run to minimise that. It's looking to carry out PSA testing on 12,000 men over a 1-year period. And as I said, we've got that pilot starting imminently in Guildford and Waverley, and focusing very much on the BAME and the family history of prostate cancer patients being prioritised. And we will share all of that information as it comes through, and where we're headed next with the project in terms of your local area. Again, we've got a checklist there, so just to use as an aid memoir going forward. So hopefully that will be useful for you. And then this is the final requirement, which is reviewing the use of non-specific symptom pathways. So there's a wealth of clinics that are being introduced across England for patients who display symptoms that could indicate cancer but don't align to specific cancers. We know often these patients kind of bounce around different TWR referrals and can end up having later stage diagnosis. And these symptoms of kind of unexplained weight loss, fatigue, vague abdominal pain, they're really hard to place where the patient should go. So these pathways are hopefully going to enable people to have a much more rapid and accurate diagnosis. They often ask for a number of filter tests to be done, but then you can get that rapid onward referral to them and filter out whether there was any sinister disease, but also other significant diagnoses as well. So I appreciate that there are, this very much depends on whether you have something in your area. So there is a clinic at Ashton St Peters and at SASH, and Frimley is looking at this as well. But it's something that, again, is going to be developed with time. So, speak to your local cancer teams about what the plans are in your area, but certainly there will be something, that your patients will have access to in due course going forward. So I think, obviously once it's available, make sure you're using it, promoting it, and aware of it. But trying to fulfill this requirement is very difficult if you don't have anything within your area at present. So I'm going to hand over to Martha-Lee, who is our data analyst expert, and she is going to share her screen and talk you through the fingertips dashboard.
Good afternoon, everyone. So I'm Marty Isaacs. I'm the Principal Data Analyst in the Surrey and Sussex Cancer Alliance. This dashboard was first developed about 1.5 years ago for the first draft, and that was really based on the fact that the fingertips data set was quite difficult to navigate through and to remember whether you could take data from CCG to PCN all the way down to GP levels. Some of the metrics is not available at some of those levels. So it was to put it all into a single sheet with charts that update automatically so that you could use that and really drill down and produce a pack to summarize the key data sets. So I'm just going to share my screen and I will ask for somebody to confirm that they can see it. It's the phrase of the pandemic. Lovely, thank you very much. So it starts off with a cover sheet at the front here. This one is from last year. We are on at the moment working really hard to get the latest one up to date, and that will hopefully be out in the next couple of weeks or so to be available. There might be some slight differences in the way it looks because we're constantly learning and trying to improve and make it better. So the first tab here is around screening coverage. And at first it looks incredibly busy. You can barely make out the labels, and that's because it's not intended to be used in this way. It's intended to be able to drill down into a specific type of metric, and drilling down whether it's by CCG, PCN, and then a specific GP practice, which is over on this side. So at the moment, I've selected it for bowel uptake. It is set to the minimum target, which is the 52%, which we can see all of the CCGs are meeting there. And even if it was the 60%, they would be meeting that. The idea then is to be going into a particular one of those. So if I went into Brighton, I'm just taking things at random. I'm not trying to identify anything in particular, just trying to show you. We can then see that the PCNs for Brighton are displayed on the side here, and we can see quite a large variation all the way from 67 down to about 57% over on that right hand side. It then tells me the different PCNs so that I could then consider whether I want to go into a particular one. So for example, if I went into East and Central Brighton 2, I can then select that PCN, and down at the bottom, I then have an update for all the practices within my PCN. And we can see here the ranges from 59 down to about 18%, and that would be a significant outlier there. So I'd be wanting to understand, is that a practice with not very many patients, or what could be the reason? If we exclude that one, we can still see there's about a 7% variation there. If I continue scrolling down, I've got a quick little summary table that tells me how many patients were screened out of how many were eligible, what my coverage therefore is compared to the target, and whether the target's been met or not. And so that particular practice, there's less than 40 patients there. So we can then at any point, so this is for the latest year that it's summarizing, I can look at previous years, or I can go down. If I'm focusing on Broadway, for example, I can go across and click on Broadway, and I can see a trend that although that practice is barely meeting that acceptable, that has been improving considerably over time, and I can repeat that for any of the GP practices. There are some hints and tips littered around the page, so do have a look, and these are called just clearing the filters, so you can click that off and then it resets it back to the start. I can then change to coverage for cervical, for example. Cervical doesn't have an uptake metric, so that's why it hasn't shown there. Again, I'm going to rely on anyone interrupting me. Please shout because I can't see any hands or screen. So it's updated again. This time I can see that this one particular area has dropped lower than the other, so it's Brighton and Hove. If I then have a look at my different regions there, I can go into cluster 5, for example, which is that one. And then I can see, again, the variation of the different areas. So, for example, Brighton Station Health, we can see that none of those areas are meeting. And we can see the volume of patients and the activity that would be associated with that. So that is the one for screening. It's got the different metrics there on the side and being able to filter back and forth between these. There are some additional fingertips metrics on there as well that are associated with cancer. So, for example, earlier was mentioned the emergency presentation, which is not on this one at the moment, but other metrics that are on here, for example, is the 2-week wait referrals and an indirectly age-sex referral ratio. So to be able to compare for over a 5-year period compared to England. So for example, if I so I haven't got CCG data for this, as I say, not all the metrics have got data for the same periods, but if I have a look at Brighton, and then I can see by my PCNs, there's a considerable range for that ratio, where some have got much higher referral ratios than national, and some much less. And then if I went into the one that's, for example, East and Central, I can then see that there's this variation between my practices. I can click on the other one, so I've got more. This practice has got an unusually high ratio, double what's at national. So it's being able to dig into that in detail and clicking on that practice in particular, which was Broadway, and then having a look at that trend over time to see that many years ago it was similar to national and it's been increasing well and above. So understanding what the cause behind that could be. So all of these data sets are also on fingertips. Fingertips can be tricky to use if you're not familiar with it, and that's why we're trying to develop these dashboards to help simplify it a bit and put some of those notes in, and it's all in a single place. So I will pause there just to see if there's any comments or anything that you want me to touch on further. I'm mindful that not everyone's got a lot of time.
Marty, there was a question about, is this all pre-pandemic data? The update that you're doing is going to be with what data?
So the data that I've just shown you, especially around screening, was for 1920. So yes, it was just up to the start of the pandemic, that March 2020 period. The latest data was for 2021. So it showed us the impact of that first year of the pandemic. And then probably towards the end of this year, we'll get 21, 22. So there's always this lag that we have for the data to come through. But so the newest data will come in for 2021.
Thank you. And there's a lot of questions about when the link is going to be shared. We're hoping that it's going to be in the next couple of weeks.
Yes, we are working super hard in the background. As you can imagine, it's a huge amount of data, a lot of mapping to make sure that we can align all the, and there's been PCN changes and CCG changes. So we're trying to make sure we align all of that. And so we're happy to get it done the next couple of weeks.
Yeah. Thank you so much, Marty. Any more questions for Marty while we've got her? I don't think that's specifically for you. Okay, we will answer that one in a second. Thank you, Marty. So just moving on to the practical next steps. So I think we've covered an awful lot, and you know, we're very aware that it can be a bit mind-blowing going through it. But I think if you stick to the templates, it does make it a lot easier to really kind of focus the mind. So really, I think it's about thinking where you want to take this. So just really looking at the different domains, just focusing on one of those particular bits in each of the areas to say, how am I going to make this work? And I think really making it smart so that you're not overwhelming yourself in the process. I mean, the data that Marty has given you or will be available, and it will be a massive help to really use your own kind of PCN level data to focus on the areas that you're doing really well in, but also the focus on the areas that you might want to look at in more depth. So and I think the beauty of this is that, and hopefully if we can establish this group as a thing that goes forward, is actually sharing some of the difficulties and the challenges that we face in different areas and learning from each other as to how we've managed to kind of get around those. So that's really just a schematic diagram of things that you could look for. As I say, smart, we all like to keep things simple, but, sometimes keeping things simple is actually really, really effective and can make massive changes. So think about what you're actually going to do, make it very specific, make it a measurable target. So, looking at X percentage of the non-responders, for example, and trying to contact X proportion of those, and then demonstrating, hopefully, an improvement in your screening and when you're going to do that by. Be realistic, you can't do everything all at once. So do one thing, and then if that works, move on to another area. Think about making it relevant to your practice population. So keep that kind of data in mind and really target the areas that you notice you have inequalities. Really try and kind of improve on that and make it relevant to your PCN area. And thinking about how long it will take, it always takes longer than we think it's going to take, but try and give yourself a timeline over which you want to achieve that by. Obviously, the end of the PCN DES year. And don't forget, we're all doing it. So we're all building a community of practice. One of this meeting today will be one of your kind of ways of demonstrating engagement with the wider community. Think about using public health. There's loads of resources out there from charities such as Macmillan and CR UK, all of which are referenced in the pack that you'll get. There's inequalities teams at ICS level. Think about, contacting the inequalities teams, because they'll have some data. They'll know, where the challenges lie, along with public health. The Alliance can give you all of that information as well. Certainly with the data that Marcelly's given us, that really, really helps. The ICS cancer teams are your kind of go-to for your own areas. And the learning disability, thank you, Kat, teams as well, to really link in for some of the work that's already happening. So you don't need to reinvent the wheel. You can use some of the things that are already going on. And think about, as I mentioned it earlier, thinking about actually having a practice care coordinator or a PCN level care coordinator for cancer that can kind of drive some of this work, that can do some of the really in-depth work for you. And keeping abreast of the national screening campaigns could be part of their role. Thanks, Steph. That's really, a little bit more on the communities of practice, sharing good practice, sharing the challenges, trying to kind of engage with the cancer learning sets to see, where these things, what other people are doing, and sharing learning is always a really helpful thing. And this is just a checklist that kind of supports that. Try and identify that you've got a confirmed cancer lead within the PCN. Think about whether you want a cancer lead at practice level. Work with the cancer leads to develop a QI project, like we've discussed. Collaboration with the wider teams, and using all the resources available to you, and thinking about your patient groups and your patient participation group and how they can support as well. Again, this is a quite a useful template that will kind of allow you to put everything in one page. Again, I'm not going to go into it in great detail, but use it as a way of focusing the mind really on what you've done and how you've achieved it, and what the difficulties have been, and all the next steps that you want to take from that. And these are the contacts for the local areas. So we're all GPs, certainly at the Alliance, Kat, myself and Alex Norman, who is our medical director, we're all GPs, so we're very acutely aware of how difficult some of this can be done, to get done at PCN and practice level. So do give us a shout if you need us. And then you've got the teams from the ICS there as well. Again, they have a wealth of knowledge and would all be able to help you. And then some of the screening and immunisation contacts as well, that you can make use of, all of whom have been very happy to share their emails with us. So I think that's probably it. The local teams are your kind of initial go-tos for your local level initiatives. For example, the Telederm will all come through the ICS kind of teams, and they will keep you updated. And along with Keely, who is our communications officer, who's waving, and she'll be sending you out bulletins here and there, to just keep you abreast of what's going on, all of which again will be hosted on our website. So that's it. We just wanted to acknowledge all of the hard work that's gone into this presentation, and all of the slides, yes, will be shared with you after the presentation, and will all be to some extent in the pack, although there'll be slightly more detail within the pack. So as usual, we would like some feedback to see whether that has been useful for you. We appreciate it's a massive topic, and I think what we want to see going forward is that we perhaps drill down into some of these areas, to look in a bit more detail. There will be things like Ardens webinars that are hosted to this group that will allow you to kind of use the tools available in a bit more robust way, perhaps, and to educate around that. So if you wouldn't mind, that would be really helpful, just so that we know where to pitch it next time, and what you want to focus on. So thank you.